the topic of my master thesis was the joint space narrowing prediction. First of all, I will tell you something about the clinical background of osteoarthritis. Then I will go on with the motivation and the problem definition of my thesis. I will explain the data I used for training the networks and how I labeled them. And after that, I will talk about the implementation of the models and the results, and compare these to other studies, previous studies, and finally the conclusions and the future work. So in 2020, 23% of the population aged over 40 years was affected by osteoarthritis. So it's a really common joint disease in the world, or the most common joint disease in the world. And especially the knee area is the most affected one. The people who suffer from osteoarthritis, they have a lot of pain and movement restrictions. And on the right side, on this image, we can see there's an increased load of degenerative enzymes in the joint. So we have a cartilage loss, and with this as well, a joint space narrowing. As well, the surrounded bone morphology changes and osteophytes are formed. In the usual case of osteoarthritis, knee osteoarthritis is developing over 10 to 15 years, but there's this special form of the accelerated knee osteoarthritis. This develops already in between 1 and 4 years. And among the whole COA patient cohort, we have 3.4 patients with the accelerated osteoarthritis. And 1 out of 7 of these patients, they get a knee replacement within a medium time of 2.3 years. So there's little time to react and find alternative solutions. Due to the lack of knowledge of the etiology and the development of knee osteoarthritis, there's no possibility to predict the accelerated form yet. Here we can see 2 examples. On the left side, there are the slow progressors, and on the right side, the fast progressor. The first image is taken at the baseline visit, and the second image 4 years later. So as we can see here on the baseline images, there's not a big difference between the slow and the fast progressors, or there's no difference we can see. Even the fast progressor has a bigger joint space width at the beginning than the slow progressor. So here's the problem, that we are not able to define this or to predict this yet. So if we could predict the accelerated form, we would have more time to find alternative medical interventions and to avoid with this knee replacements, which would reduce a lot of pain and as well costs. As well, we could improve the research of modifying drugs for osteoarthritis, because we would have a more uniform cohort of patients to test the drugs. So my question is if it's possible to predict accelerated knee osteoarthritis using a convolutional neural network, if we would define the accelerated form with a joint space narrowing per 2 years. So the data I used to train my models, I took them out of the datasets of OEI, MOST, and CHECK. The data or the patients from OEI and CHECK were followed over 10 years, and from MOST over 7 years. And each patient was visited in an interval of 1, 2, or 3 years. So all participants of the studies were aged between 45 and 85 years, and the inclusion criteria was either the presence of pain and or stiffness in the knee, or they had if they had characteristics which lead to an increased risk for osteoarthritis. So for example, if you have a high BMI or a previous knee injury or surgery. Like this, we have from one patient several knee images. For example, here the patient has 5 images from year 0 to year 8. And now we want to label the images with fast or slow progressor. So we need to calculate the joint space narrowing, and therefore we have to we need an image 1 or at least 2 years later. So like this, we have here 3 intervals of the data we can use. For the first year, or the first interval is 1 year between the visit 0 and visit 1. And for example, from visit 1 to visit 3, we have 2 years, so we could calculate here as well. I used the first image and the second image 1 year later. And so I calculated with Koala the joint space width and could calculate with this a joint space narrowing over this time range, in this case over 1 year. So if this patient shows joint space narrowing of less than 20% per year, it's a slow progressor. If it's more than 20%, this would be class 1, a fast progressor. Like this patient provided us with 3 labeled images, twice class 0 and 1 with class 1. As well, we excluded some of these patients. We excluded non-progressors because we only wanted to classify between fast and slow progressor. So the patients with KL0 at baseline and KL0 at the end, at the last visit, and with KL1 at baseline and KL1 at the last visit, we excluded, and as well the ones with KL4 and an implant at baseline visit. So now the implementation of my models. First, I implemented an XGBoost model to train only with the numeric data. And after that, we wanted to include the image as an input in the convolutional neural network model. So first, the extreme gradient boosting machine, this is the XGBoost model. We used the numeric data which is listed on the left side. Most of it we took out of the studies OEI must check. And we as well had some radiographic information out of Koala, the KL grade, the ORSI score of sclerosis, and osteophytosis. And with this we could predict, or the XGBoost model could predict between slow and fast progressor. The first results were from when we applied the exclusion criteria I said before. So we just classified between slow and fast progressors. Here we could achieve an AUC of 0.66. The RUC curve for this can be seen on the left side. Here the blue curve is the plot of the true positive rate over the false positive rate, and in AUC the area under the curve is the area under this blue curve. The orange line would be random guessing, so we're better than random guessing, which is until now we cannot predict a COA better than random. So, and on the right side we can see the confusion matrix. The confusion matrix, or for every point on the curve, we have a confusion matrix where we have a different sensitivity and specificity. And we selected this point because it's more important to extract the fast progressors than the slow progressors. So if we would predict an actual slow progressor being a fast progressor, this would not harm the patient, but it would definitely be worse if we could not predict a fast progressor and tell him he would be a slow progressor. So we also extracted the most important features for this. So the most important were radiographic information, sclerosis, KL grade, and as well the contralateral COA, which is defined with an KL grade larger than 3 or larger than 2. So the other experiment we made was when we included the non-progressors. Here we had a larger class 0 and yeah, the same amount of class 1 images or patients. Here we could achieve a higher AUC of 0.7 because, yeah, on one hand we had more data to train with, and as well the difference between the non-progressors and the fast progressors is higher than just between slow and fast progressors. So it's easier to classify between. To now add the radiograph to the model, we used a convolutional neural network, which architecture was based on the ResNet-50. After the 4 convolutional blocks, I added an input layer where we could add the gender, BMI, and KL grade of the knee and the contralateral knee. We did not use the sclerosis or RC score because this information should actually already be contained in the X-ray. And this model could also then predict with this information or classify between the slow and the fast progressors. With this experiment, with again excluding the non-progressors, we could achieve an AUC of 0.69. Which was compared to just using the numeric data higher. So the image definitely brought as well some information for the prediction. And yeah, with a sensitivity of 0.88 at the red point on the ROC curve. This experiment we also performed with the non-progressors. Here again, a higher result could be achieved of 0.76. Which was also higher than the XGBoost results with the numeric data. And here we could also have a sensitivity of 0.93. So to compare these results now with previous work, I looked at 2 similar studies. First, the study from Teopin et al. They classified between non-progressors and progressors. So the progressing class was slow progressors and fast progressors. And they had as well a different definition of the progressing knee osteoarthritis, because they used the KL grade for this. And they said if the patient increases, or the KL grade of the patient increases in the following years, it's a progressing patient. But only if it's not from 0 to 1, because this is too little to be a progressor. They also trained on OEI and MOST knees, but they split this up, so they only trained on OEI and tested on MOST. And the technical approach can be seen on the right side. So they used the X-ray, the knee X-ray, for the input of the convolutional neural network to predict the KL grade and the progression. And they as well added the numeric data, which was as well age, gender, and BMI, and as well information about previous surgery and injury. And as well the KL grade, which was assessed by a radiograph, by a radiologist. And yeah, here they used as well the gradient boosting machine to classify. On the right side, we can again see our class splitting. So this was different, and this can be this can explain why they achieved higher results. They had an AUC of 0.75 for only the numeric data, and including the image data, they achieved 0.8. But yeah, it's not easy to compare since they have different class definitions and class splittings. The second study I had a look at was from Guan et al. They also classified between the non-progressors and progressors, but they had a similar definition of progressing COA like we had. They used an absolute number of joint space narrowing of 0.7 millimeters per 2 years, which is about between 10 and 25% from the baseline joint space width. And they only trained with OEI data. They trained with only 1,400 knees and tested on 400. So they had less data than we used. And on the right side, we can see the model structure. So they also had a convolutional neural network to extract the region of interest and then predict between progression and non-progression. And as well, they used some risk factors. Once they used the numeric data used can be seen here. They used as well age, gender, BMI, and KL grade, but in addition as well the ethnicity and as well history of the knee injury. And so for only this data, they had a lower result with an AOC of 0.66 than we had, but they had higher results for adding the image at the input and reach an AOC of 0.86. So again, it was a different problem and different class definition and splitting. So to summarize my results again, once for the only using the numeric data with the XGBoost model, and once the numeric data and the image data for the convolutional neural network, we can see we definitely achieved higher results using the image data, and of course when we include the non-progressors because of the large or big difference between the non and fast progressors. And even if the other studies achieved higher results, we can say our problem could be more relevant for hospitals because we don't have that many radiographs of non-progressors, because when you don't have symptoms or pain in the knee, you would not go to make an X-ray, and therefore this problem could be more relevant. And until now, there's no really a prediction method to predict or to classify between the slow and fast progressors by looking at the baseline image. And so every result which is better than random guessing would be an achievement for this. And in future work, we could also test using some other numerical features, like for example, ethnicity or previous surgery and injury of the knee, and test how this would change the performance of the model. And as well, we could use a pre-trained network, which is pre-trained on knee radiographs. We also wanted to use these, but our pre-trained network, which we had available, was also trained with the images we wanted to use for validation, and therefore the image or the network would have identified the image as a whole and could not really bring reliable results.